Hey guys, welcome to our lesson on infectious diseases and sepsis. Infectious diseases are illnesses that are caused by infection, by some type of infestation to the body by a biological organism. These can be anything from bacteria, viruses, fungi, protozoas, even worms. Now, most infectious diseases are not necessarily life-threatening. Typically, the patient will recover. However, there are some types of infections such as HIV, Hep B, Hep C, and even things like bacterial meningitis that are particularly dangerous and may result in death or even permanent disability to our patients. We oftentimes forget about the fact that patients who survive a disease oftentimes are going to have life-altering circumstances because they were infected. It's not just as easy as you get an infectious agent or infectious disease, you get over it and you're back to normal. Most of the time that's the case, but not always. Sometimes it leads to organ failure and organ system damage and even potentially death to the individual. Now, as a healthcare provider, you must maintain a strong working knowledge of public health principles and infectious diseases. This is especially true for you guys as future paramedics. You're often going to be the first one to encounter this communicable disease, and so your ability to recognize and begin the process for controlling the spread of that communicable disease is utmost important, really to help protect others. Now, throughout this lesson, we're going to discuss infectious diseases, including the types and characteristics of specific disease-causing organisms, functions of the immune system. We'll talk about some general pathophysiology of infectious diseases. And really, most importantly, we're going to emphasize the specific diseases, discussing those that you are going to encounter in the field, most likely, through either inter-hospital transports or out-of-hospital care that you may encounter in the field. Because, obviously, infectious agents are everywhere, and we're going to have to learn to live with them. And in order to make sure that we're able to do the best for our patients and for our community, we really need to have a strong working knowledge of infectious diseases. So let's jump into what this will look like. Now, topics for this lesson are going to include public health, principles and agencies. We're going to talk about microorganisms. We're going to talk about contraction, transmission, and stages of the disease or diseases. We're going to talk about how the body has a defense against the disease process that's invading. We talked a lot about this when we were dealing with immunology, primarily focused on allergic reactions, but we'll dive into it a little bit deeper. We're going to talk about infectious control in the pre-hospital setting. And then what do you do? How do you assess a patient who has a infectious disease? What do we need to do? And then we're going to spend a significant amount of time talking about selected infectious diseases. What are the specifics that we're going to be dealing with, and how do we recognize those? How do we treat those patients with those underlying conditions or those potential diseases? And last but not least, we're going to talk about patient education and preventing disease transmission. So with that, we know that infectious diseases, illnesses, are caused by an infestation of the body's infestation of the body by a biological organism. Again, we talked about this right from the get-go. These are a number of different pathogens that can enter into the body that can cause harm to the normal process of homeostasis. Again, as a healthcare worker, as a healthcare professional, as a future paramedic, it's important that you maintain a strong working knowledge of both the public health principles that are in place to help prevent the spread and help recognize the onset of a disease, and then even more so the specifics in regards to an infectious agent. Now, when we deal with public health principles and agencies, there's a number of them that we have to look at. The primary principles we look at is going to be really taking a look at what is the disease, what do we know about this disease or this illness that's striking the community, all right? What is the epidemiology of that? What is the study of that illness? We know that epidemiology is really focused around primarily investigation and identification of an underlying illness. Now, the epidemiologists are going to study this disease. That's the whole purpose of them, is that they study infectious disease in order for them to be able to determine and prevent any type of outbreak, right? So help to predict what might be coming and help to prevent those cases from future occurrences. Now, there's also a component of epidemiology that looks around the release of an infectious agent or the exposure and the multitude of that infectious disease growing and spreading. And we look at that first initial case as we call it an index case. That index case refers to that as the first ground zero, point zero for an infectious disease. And from that point on, we really can start to track where this disease is going and how it's going. Now, beyond that, there's a number of agencies that are going to help us carry out that mission of identifying and then predicting and continuing to prevent the spread of that illness. These agencies include your local health department, include state health departments, the Department of Health and Human Services, and then even different components from federal agencies such as the CDC, NIOSH, OSHA. At the state level, we have MyOSHA. Those components, they're designed to really take a look at the ways in which people get hurt or have illness, and ways in which they can help prevent that, really focusing on the illness component. Now, when we look at microorganisms, the vast majority of disease-causing organisms are microscopic, right? They're only visible underneath the microscope. Now, these microorganisms are all over the place. They surround us. They're in our skin. They're in the air we breathe. They, believe it or not, colonize virtually every orifice of our bodies. Now, some can even live in extremely acidic environments like our stomachs, which is really, that environment is designed to kill other pathogens. Now, the majority of these are known as normal flora. Normal flora helps us keep us disease-free by creating an environment or environmental conditions that are not conducive to disease-producing microorganisms or pathogens, right? Now, competition between colonies of normal flora and pathogens also discourages the survival of pathogens, right? So it helps create an environment that are unlikely to be able to survive. Common bacterial pathogens include things like staph, infection, strep, and then other types that we can see, things of viruses or fungi, protozoas, are also considered to be pathogenic. Now, the last one we look at here is opportunistic pathogens. I can never say this. Opportunistic pathogens are ordinarily non-harmful bacteria that cause disease only under unusual circumstances. Most opportunistic pathogens are normal flora by nature, and patients who have a weakened immune system or who are under unusual stress may become susceptible to disease caused by a opportunistic organism. Now, when we look at bacteria, bacteria are microscopic single-celled organisms that range in length anywhere between 1 to 20 micrometers. Now, these living cells are classified as paroxytes because they do not have a distinct nuclear membrane, and they possess only one chromosome and one cytoplasm. Now, bacteria reproduces independently, but they do require a host supply and food in a supportive environment. You have to remember that when we're talking about pathogens, the body serves as a host to that infectious agent or to that pathogen. Most bacteria are easily identifiable by staining, where they actually get stained underneath a microscope, and by doing so, they can differentiate the different types of bacteria. Bacteria that typically turns purple, we would call those processes gram-positive. Those that turn red are considered gram-negative. Because of the similarities in their cell walls, bacteria that stain alike typically will respond to similar treatment. So we can start to classify those based on the types of maybe antibiotics that we're going to administer. They'll be effective for that specific strain of bacteria. Now, they're also categorized based off their shape. Bacteria are grouped based on their general appearance. The spheres are obviously going to be round. You can see rods are going to be more elongated, and spirals are going to be collator. They're going to curl up into a spiral. Now, a lot of these different ones that you're going to see, bacteria-wise, may cause harm to the human host in a number of different ways. Heavy colonization may result in a direct damage to the tissue as the bacteria feed. Bacteria also cause indirect damage to the host by releasing toxic chemicals that can either have a localized or a systemic effect. The two general categories of toxins are exotoxins and endotoxins. Exotoxins are poisonous proteins shed by bacteria as they grow. They stimulate the immune system to form antibodies for these proteins, and these chemicals, light or heat, may also begin to deactivate them. Exotoxins are more toxic than endotoxins. For example, the infectious agent of a toxic shock syndrome, like staph, releases an exotoxin, as does anthrax, which can be delivered as a biological weapon of mass destruction. So again, there's the types of bacteria we typically look at are the three. They're going to look at spheres, rods, and spirals. And that was primarily focusing on exotoxins. If we focus on endotoxins for a brief moment, we know these consist of proteins, typically larger sugar molecules, and lipids. The immune system cannot form antibodies specific to a particular endotoxin unless both the protein and the sugar portions are present. Endotoxins come from the bacterial cell wall and are released when the bacteria cell is destroyed. So in this case, we're talking rather than them building up and reproducing, endotoxins are released when they're destroyed. They are more stable in heat than exotoxins. Only gram-negative bacteria make endotoxins. And the last part of this is referring to antibiotics. There's two primary types of antimicrobial treatments that are going to alter the normal flora of the skin, mouth, mucosa, GI tract, and often results in colonization of these areas by new microorganisms that resist antibiotics. Most bacterial infections respond to the treatments with antibiotics, either bacteriocide, which kill bacteria, or bacteriostatic, which inhibits bacterial growth and reproduction. Antibiotics are prescribed based on bacteria sensitivity, so different antibiotics are required to treat different types of bacteria, different forms of bacteria. Typically, their administration decreases the bacterial presence and reduces symptoms. Some of these bacterial infections respond quickly to antibiotics. Others take longer. In recent years, a number of bacterial strains have developed resistance to antibiotic therapy, making treatment even more difficult than it was before. Most types of bacterium that's exposed to an antibiotic, or probably the more that you would see that's exposed, you're going to see the greater likelihood of it developing a resistance. One of the most common and most effective initial treatments we had in the form of an antibiotic was penicillin. Penicillin is not widely used today like it was during its creation. And oftentimes people think that's because, well, it's just not as effective as newer forms of antibiotic. Well, that might be true for some drugs. The primary reason is we know most of the strains of antibiotics that we utilize, the different kind of offspring, if you will, of the different forms, because they're so effective, if we were to overly use them, we know that the bacteria would most likely become resistant to that treatment. And no longer would we have the great tool of antibiotics in our toolbox if we overuse it. So that's something kind of interesting to think about. Viruses are much smaller than bacteria and can be seen only with an electron microscope. They're that small. Viruses cannot reproduce and carry on metabolisms by themselves. They are host dependent. They are what we would refer to as obligated intercellular parasites, a fancy way of saying that they can grow and reproduce only inside of a host cell. So you can see on the image that's denoted on the PowerPoint presentation. Now, once inside, the virus takes control of the host cell's protein synthesis mechanism and directs it to begin reproducing the virus. The cell then releases the new virus particles, which begins to infect nearby cells. Now, because this virus actually hides inside the cell host, they resist antibiotic treatment because they're inside of a healthy cell. Now, once the virus enters that host cell, it becomes part of that host cell, making selective eradication of the virus virtually impossible. Any treatment capable of killing the virus will in turn kill the host cell as well. Now, this major obstacle facing researchers, they're trying to do the best they can to overcome, but it's been a very hard thing for them to do as far as treating things like HIV or other viruses. There are approximately 400 different types of viruses that have been identified. There's probably even more that haven't been. One frequently encountered viral disorder, the common cold, is caused by a number of different viruses. Almost 200 different viruses cause the common cold that produce all of the same type of similar symptoms. Now, fortunately, most viral diseases are mild and self-limiting, right? We know that. They run their course until the patient's immune system eventually fights them off. A host generally is susceptible to any particular virus, but typically only once, right? They're exposed, and at that point, the person's immune system develops active immunity against that particular type of virus. It becomes unattuned to similar attacking viruses as it will then recognize them seek them out, and destroy them. Now, there are also other forms of microorganisms that we typically deal with, and there is a lot of them. You can see them here. Most of these have been talked about as we go through the TED. There are a ton of different other microorganisms that you can see. Prions, fungi, protozoas, parasite, pinworms, hookworms, trichinosos. All of those are different components that we may see throughout our infectious disease agent. It's very hard for us to determine the specific type of microorganism that we're dealing with in the field, but they're treated no differently than any other infectious agent. Let's move on to talking about the contraction, transmission, and stages of disease. Now, as a paramedic, you must understand the relationship between the pathophysiology and the assessment and management of patients with an infectious disease or infection resulting from some type of exposure to a pathogen. This knowledge will prepare you for the leadership in recognizing infectious diseases and curbing their transmission. Now, when we think about the interaction among the host, the infectious agent, and the environment, all of these elements are essential for proper disease transmission. Studying each of these factors individually and then looking for relationships among them reveals how infectious agents have been effectively transmitted. Infectious agents exist in all types of reservoirs. We recall a reservoir anything that's an animal, a human, an insect, or even the environment. Now, while inhabiting an animal or insect reservoir, they do not cause the disease. Their presence at any time in a given environment is affected by their life cycle, by the presence of stressors that may force them outside of their normal reservoirs, and by things like climate. The initiation of therapy can sometimes disrupt the life cycle of this infectious agent and may eradicate the infection. When a host and infectious agent come together at the right time, under the right conditions, disease transmission will take place. Now, we also know that infectious agents may invade a host through one or two basic mechanisms. The more common is direct transmission from person to person through a cough, sneeze, kiss, sexual contact, things along those nature. The other mechanism is indirect transmission, which can spread the organisms in a number of different ways. Infected persons often shed organisms into their environment. These organisms come to rest on things like doorknobs and handrails, computer keyboards, and so on. Other people who contact these surfaces are at risk for contracting the disease. Similarly, microorganisms may be transmitted via food products, water, or even through the soil. Now, when we think about these, blood-borne diseases are transmitted by obviously contact with blood or bodily fluids of an infected patient or infected person. These include things like AIDS, hepatitis B, C, and D, the Ebola virus, syphilis, coronavirus, and a number of different other viruses or other infectious agents. The risk of transmission of bloodborne diseases increases if a person or patient has an open wound, active bleeding, or an increase in secretions. So assume that every patient that has an infectious bloodborne disease and take the precautions to avoid them, especially if we're dealing with blood or bodily fluids. Now, some infectious diseases may be transported throughout the air or by droplets expelled during a productive cough or a sneeze. They include things like tuberculosis, meningitis, mumps, measles, rubella, and varicella or the chickenpox. Other more common diseases such as the common cold, influenza, and respiratory syncytial virus, RSV, may also be transmitted by the airborne route. The idea behind this is that we really have to start to recognize whether the risk of infection is considered theoretical in transmission and is acknowledged to be possible but not actually reported. That would be an example of a theoretical. It's there, it's potential, but it's not actually been reported yet. We know that it could spread though. And if it's considered measurable, if the factors like things with the infectious agent's transmission and their associated risks have actually been identified or deduced from some type of reported data. That's an example of a measurable transmission or contraction. Something we can actually physically measure versus more a theoretical approach. Now, generally, the risk of disease transmission rises, again, if we know that they have some type of active infection where they're having coughing or increase in secretions, open wounds, anything along those lines, even performing invasive procedures such as an IV or intubation. These all are going to increase the likelihood of exposure. In the pre-hospital setting, the unpredictable environment and behavior of patients increase the risk of exposure. For example, a patient with a closed head injury and multiple lacerations may become combative, and as they become combative, they're going to contaminate their environment at a much higher rate than if they were to be compliant. Patients who are violent or aggressive may deliberately bite, they may scratch or spit at rescuers, and many EMS patient care activities occur in a closed, poorly ventilated environment, like, guess right, the back of an ambulance. So you must make sure that you have available and routinely used protective clothing, other barrier devices as indicated, and then regularly clean and sanitize the ambulance and equipment that you use to help reduce the spread of any disease, right? Reduce the spread and reduce a cleaner, safer environment for your patient to be in. A lot of our patients also are going to be immunocompromised, and introducing them into an environment where there's a potential for infection because of lack of concern on our part or lack of cleaning or disinfecting of the equipment and the space that we utilize puts that patient at a higher risk. And the goal of when you call 911 is not for us to cause a problem, but more so to help an emergency. Now there's table 10.1 in your chart, talks about the modes of transmission of infectious diseases, and you can take a look at that throughout your book, but it's going to go over all the primary components you can see. A lot of them are going to be bloodborne, airborne, or sexually transmitted. Just to go over a couple key things that we've talked about here, factors affecting disease transmission include things like mode of entry, how easily can it get into the body, including things like open wounds or inhalation, lack of protective equipment. We also know that how likely that the pathogen is to persist, right? As it tries to continue on, how well will it be able to do that? And then we need to know the number of organisms that were transmitted, right? We get a high exposure, we're going to have a lot more risk. Lower exposures, typically lesser risk. We also need to know about the host, right? Is the host in a position where it's going to be able to resist the infection? In a normal healthy adult, that might be the case, but a patient who has underlying chronic illnesses or maybe is immunocompromised, they're going to have a harder time fighting that infection. We also know that things like contact and age oftentimes will play a major role in how effective. If we look at the phases of the infectious process, disease progression varies greatly. It's going to depend on the infectious agent and the host. Now, conditions can manifest themselves in a variety of ways. Once infected with an infectious agent, the host goes through a latent period where they cannot transmit the agent to someone else. So even though they're infected, they still can't spread it. That's the latent period. Following the latent period is where we pick up with the communicable period. Now, this is when the host may start to exhibit signs of clinical disease and can transmit the infectious agent to another host. Not always, though, do they show symptoms. That's critical. We also know that the appearance of signs and symptoms can lag after exposure to an infectious disease. So the time between exposure and presentation of symptoms is known as the incubation period. Now, the incubation period may range from a few days, such as the common cold, to months or years, as we see with HIV, AIDS, or hepatitis. So in the pre-hospital setting, personnel must be notified if any patient who they provided care with subsequently develops a life-threatening infectious disease. That becomes extremely important for us. We want to be able to recognize that as best we can. Now, As we look into this, most viruses and bacteria have surface proteins, right, or what we refer to as antigens, that stimulate the body to produce antibodies. Now, these antibodies react or will unite with the antigen. The antibody's presence in the blood indicates an exposure to the disease that they are fighting. Now, although testing for the presence of a specific disease antigen is very difficult, laboratory tests can often spot antibodies that are specific for a disease or antigen. For example, HIV, right? For a long time, we were trying to detect the HIV virus. We were looking for specific antibodies to be able to tell if they had the disease or not. When a person develops antibodies after exposure to a disease, his previously negative test will now be positive. And we know that there's actually that presence of the infection has occurred, or that they've gotten over that infection. Now, the time between the exposure and the circumvention is referred to as the window phase. Now, the window phase, a person in the window phase may test negative even though they are infected. This is where testing oftentimes can become very frustrating, because depending on where the patient is in their infection will determine if they're going to show a positive result on the test. Now, the time between the exposure of these and the circumvention we said is the window phase, and a person in the window phase, we know they can test negative even though that they're infected. From that standpoint of the immune system's response, the window phase is a period where the antigen is present, but the antibody production has not yet reached to a detectable level. It's not that it's not beginning to work, it's just too early on for a test to be able to pick up the body's natural response. Now, we know that with the disease period, the duration from the onset of signs and symptoms until the resolution of the symptoms or death is going to occur. That's the design of the disease process, right? It's from onset to resolution. Keep in mind that the resolution of symptoms does not necessarily imply that the infectious agent has been eradicated. It may just be in some type of remission. So let's take a good look now at the body's defense against disease. When we think about the body's defense against disease, one of the big things we have to recognize is the body protects itself from disease first, and it does so in a multitude of ways. At the most basic level, we deal with the skin. The skin, truly, the integumentary system, protects us against invading infections and pathogens. Parts of the respiratory system assist by creating turbulent airflow that will capture foreign bodies in things like nasal hair. Mucus can help trap and kill foreign materials transmitted to them by the mouth or the nose, and then allows for us to expel those out in the form of sputum. We also know that nicotine from cigarette smokes paralyzes the individual cilia that actually help us expel any type of that lower airway mucus. That's why we often see those that are smokers having a difficult time clearing that phlegm. We know that the urinary and gastrointestinal systems also work cooperatively to eliminate pathogens through the feces and through the urine. 3 body systems that specifically protects against the disease are the immune system, the complement system, and the lymphatic system. And we'll take a look at those in detail. As we look at the immune system, we know from our previous components, fights disease by protecting the body from foreign invaders. It must be able to differentiate the individual self from non-self, right? From abnormal invaders. The immune system can recognize the antigens of most bacteria and viruses as foreign or non-self. Once the immune system has identified the material as non-self, it's going to start a series of actions intended to eliminate that foreign material. The series of mechanisms initiated by the inflammatory response, which result from local tissue injury, are all part of this as well, and it's what leads to the presentation of this infection, right? It gives us the ability for us to take a look at where it's coming from and how it's being produced. Let's talk about infection control in the pre-hospital care. Let's talk about infection control in pre-hospital care. Now, obviously the body has its own ability to defend against infection. However, EMS providers must protect themselves from an infectious exposure as well. We know that when we're dealing with contagious patients, it's important for us to try to minimize our exposure so we can continue to help others and not transmit that disease. If we think about the primary 4 steps of this infectious control phase-wise for pre-hospital care, we have to look at the primary component of this, the preparation for response. Our goal is to interrupt the infectious disease transmission cycle. And as part of being a pre-hospital care provider, dealing with infectious agents, it's important for us to be aware of how we can break these. First is your preparation for response. Infection control really does begin long before an emergency call starts. To make sure that you have the proper protection, you need to make sure that you have a number of following procedures that we'll discuss in place. These include things like standard operating procedures and how to deal with infectious control, how to monitor employee compliance, how to prepare an infectious control plan that includes a schedule when and how to implement specific standards from federal and state organizations, local organizations, how to provide adequate original and ongoing infectious control training to all personnel, including injury and work practice controls. We also want to ensure that all employees are provided with personal protective equipment that fits appropriately, that's regularly checked and maintained properly, and can be located very easily by the provider. We want to ensure that all EMS personnel treat and bandage all personal wounds, any cuts or skin breaks before an emergency response happens, that we're again using disposable supplies as often as we can, that we have access to the facilities and supply needed to maintain a high level of personal hygiene, that we don't allow EMS personnel to deliver care if they exhibit any types of signs or symptoms of an infectious disease, monitor all EMS personnel for compliance with vaccinations and appropriate diagnostic tests, antibody titers, things of that nature, and then make sure that we have a specific infectious disease control officer or IDCO that will serve as the contact person for physical exposure to an infectious disease and monitor their infectious disease control program. Identify specific job classifications and work processes in which the possibility of exposure exists, and finally provide hazmat or hazardous material education for employees, including how to locate and interpret safety data sheets, SDS, regarding chemicals or chemical mixtures with information on localized health hazards. So as part of this preparation for a response, don't assume that your EMS agency can truly protect you from all exposures in regards to an infectious agent. Really, your attitude towards protecting yourself is going to be the basis of your professionalism, and beyond that, it's going to allow for you to help prevent the spread of disease. That takes us on to our second step, which is the response. When we think about the response, we want to obtain as much information as possible from dispatch before we actually get there. We want to try to prepare the patient, prepare for patient contact, and then prepare mentally for the call. The idea behind this is put on your gloves, don your eye protection, whatever personal protective equipment you might need, and think infectious control. You really do have to get yourself into the mindset of that. I think part of this recent issue with COVID-19 has really put us into the mindset of being aware of infectious disease, how often we touch our face, how often we wash our hands, how we treat regularly used surfaces and social distancing, the amount of space between people to reduce the risk of spreading an infectious disease. Those core components are going to help you really prepare. Last is going to be preparing for patient contact. Once you make patient contact, you want to isolate all body substances, wear personal protective equipment, allow for only necessary personnel to make patient contact, use airway adjuncts for assisted ventilation, and use disposable items whenever possible. Most of the things that we've been talking about with COVID-19 really do focus on these core patient contact infectious control principles. Recognize it, get yourself into the mindset, and then make sure you don the proper protective equipment. For patient contact, we want to again properly dispose of any biohazardous wastes, including biohazard bags or sharp containers. If we're using sharps or any type of instrument that would contain a sharp, that we immediately dispose of those in the proper container as well. Never smoke, eat, or drink in the patient compartment of the ambulance. This is hard oftentimes when you're a third rider. That's maybe the only place you have to sit to eat your lunch, but you may want to step out of the ambulance or find a better location because you're exposed to pathogens in that environment. Don't ever apply any types of cosmetics or lip balm or handle any type of eye contacts when a possible exposure exists. The goal of this is be smart. Be aware of what you're touching, or pardon me, what you're working with, what it might have on it as far as an infectious agent, and then dispose of it properly as quickly as you can. There is a number of different components as far as what specific guidelines you might need for PPE, depending on what the task you're doing, and then the different levels in which you may need to utilize PPE. In the recovery phase, this is the most important part. Wash your hands immediately after patient contact. If you don't have soap and water readily available, which is understandable, use things like hand sanitizer or other disinfectant wipes. Make sure that you're cleaning your ambulance regularly with disinfecting wipes or even a 1 in 10 solution of bleach. But as soon as you can, and as soon as you have access to water and soap, wash your hands. Hand washing is the #1 way of preventing the spread of disease. We also know that anything that's infectious, we need to contain. We need to bag and label any soiled linen. Decontaminate anything that was contaminated from your personal uniform to the equipment you may have used that's reusable. And then, again, your organization should have a uniform policy that what do you do with it if it becomes contaminated. Some will send it to a dry cleaner for you. Some have a specific washer and dryer on the premises that you may use to disinfect and clean. But follow your own primary policies for that. When we deal with decontamination, we're really talking about making sure that anything that that the patient, a suspected patient came in contact with, is properly cleaned. You're typically going to have some type of SOPs established by your agency as far as when and how to perform decontamination. It needs to be performed in an area that's designed for cleaning. The room should have suitable ventilation, adequate drainage. You need to be able to wear gloves, gowns, boots, protective eyewear, and face masks. The first thing you're going to do is remove any type of contaminants, surface dirt, or debris with soap and water. Then disinfectant and, if required, sterilization of all items. There are 4 levels of decontamination, everything from low-level disinfection all the way up through high-level disinfection, including above beyond that even of sanitation. We don't sanitize things in the ambulance. We don't have the ability to do that. Equipment may come in a sterile packaging, but as soon as it's opened, it's no longer sterile. So it's very difficult for us to reach that level of decontamination in the pre-hospital setting. Let's go ahead and go through each one of these. The first one that we look at is low-level disinfectant. Low-level disinfection destroys most bacteria and some virus and fungi. It does not destroy things like tuberculosis or any type of bacterial spores. Use low-level disinfectants for routine housekeeping and cleaning, as well as for removing visible bodily fluids. And all EPA-registered disinfectants are suitable for low-level disinfection. Intermediate-level disinfection destroys tuberculosis, right? And most viruses and fungi. It does not, however, destroy bacterial spores. It's used for equipment that has come in contact with intact skin, such as stethoscopes, splints, blood pressure cuffs. In this case, we're talking about a 1 in 10 or a 1 in 100 dilution of water and chlorine bleach is acceptable for intermediate-level disinfection. Hard surfaces, germicides, and EPA-registered disinfectant or chemical germicides are also effective as intermediate-level disinfectants. High-level disinfections agents are going to be dealing where they're destroying microorganisms, all forms of microorganisms except certain types of bacterial spores. High-level disinfectants are required for all reusable devices that come in contact with mucosal membranes, including things like laryngoscopes, McGill forceps, and airway adjuncts. For high-level disinfections, immerse the object in EPA-approved chemical sterilizing agent for 10 to 45 seconds, depending on the manufacturer's instructions. Alternatively, immerse the device back into hot water and let it soak for up to 30 minutes, for at least 30 minutes. Sterilization is the last and at the highest level of decontamination. Sterilization destroys all microorganisms and is required for all contaminated invasive instruments. Typically, you'll hear this used as what they refer to as an autoclave. An autoclave that utilizes a pressurized steam or an Fe oxide gas effectively sterilizes all of the equipment. These methods, however, are rarely available outside of the hospital setting. So we may get equipment from the hospital that's been sterilized, but we don't always have that in the pre-hospital setting. Alternatively, prolonged immersion, somewhere between 6 to 10 hours, depending on the manufacturer's instructions, and an EPA-approved chemical sterilizing agent is usually adequate. When possible, use disposable instruments for all invasive procedures, and typically we do that now. Everything down from even a laryngoscope blade. Some services are actually disposing of laryngoscope blades with each patient. When we think about infectious disease, again, the exposure, we have to be able to report what we know, because without reporting, we're not going to be able to track the exposure. Infectious disease exposure occur during all hours of work shift, and because you're not always able to contact an agency administrator, you need a working knowledge of your agency's standard operating procedures, as well as what laws and regulations are applicable to exposures. There are a number of recommendations that will help with this exposure management, in essence, help protect you, other emergency responders, and other healthcare professionals, along with the agencies, and then any confidential patient information that are all involved in a potential exposure. Now, when we look at the assessment of a patient with a specific disease, we have to recognize a number of things. One of the primary ways that we will deal with an infectious patient is to treat them like any other patient. We have to often recognize that in the height of infectious disease and the concerns and fears associated with it, that your assessment really won't change much in the way in which you provide your assessment. It does become difficult to build a bond with your patient because of the amount of PPE you may need to don. So your general approach will remain the same. But before you make patient contact, or as soon as you recognize an infectious agent is potentially there, don your personal protective equipment. Most of the general assessments that you're going to be able to isolate or identify in a patient with a potential infectious disease include things like unusual skin signs, maybe a rash, a fever, weakness, maybe they've got significant amounts of sweating, malaise, or anorexia. Now, there are other signs that are more localized for an infection. These include things like redness and swelling, tenderness, maybe even some type of capillary shrinking, where we can actually see the infection moving into the blood, and then warmth around the area of infection. We may also see things like a presence of a rash or other diagnostic skin signs that are going to allow for us to recognize the specifics of that infectious disease. Your past medical history will remain primarily the same. We're going to focus on the illness at hand. What history have they had in the past that could be affecting what's going on now? Have they suffered from AIDS or an autoimmune disorder? Maybe they have underlying diseases like hypertension or heart failure or COPD. Have they had any type of organ transplants? Maybe they're taking immunosuppressive medications, such as steroids. We also want to pay close attention to what their history tells us. When signs and symptoms began, it's going to really allow for us to know at what point in time did the infectious disease have a potential to spread, and maybe we can try to identify or begin to identify what that index case might be. We want to recognize when were the transmission portion of the disease. Do they have a presence of a fever? And if they say no, are they taking some type of antipyretic medications that could be reducing or eliminating that fever from our ability to detect? We also want to recognize and see, do they have any weird symptoms such as neck pain or neck stiffness? Oftentimes that can be associated with some form of meningitis. Do they have difficulty swallowing or airway concerns or issues? That may be another sign of dealing with something with, for example, epiglottitis. And then, have they had any previous similar episodes of an illness like this or symptoms like this illness? That again is going to help us to identify what happened in the past and what's going on now. Your physical exam should really remain the same. There are some key things that we want to assess for. Anytime we're dealing with an infection, a temperature is one of the most important vital signs that we can determine, to utilize, to determine if the patient has an infection. If they have a fever, not always will they have a fever with an infection, but when they do, it allows for us to begin to identify that and go down that treatment pathway. Things that we want to look for beyond a fever include things like hypotension and dehydration. I always like to have my patients stick their tongue out at me. It gives you the ability to look at their tongue, look at their mucous membranes, and see how well they are hydrated. It allows me to see things like the color of the mucous membranes, and it also allows me to do a quick neurological exam on them as well. We also know that we're going to pay attention to issues with neck flexation. Any type of neck pain, moving of the head back or forward, tucking their chin to their chest, all those things can be sign of, again, of a form of meningitis. Lymph node swelling, again, we know the lymphatic system is part of that response, the inflammation, the inflammatory response, the immune response. We may see swelling or tenderness of lymph nodes. Breath sounds, obviously, may be altered, something advantageous. We may see an enlarged liver, hepatomegaly, or even different types of certain lesions, issues where we're seeing sores that begin to develop on the body. Now, there's a lot of specific selected infectious diseases. We're going to spend time going through each one of those to kind of give you a good overview of what you might anticipate.